segment of today's session. So I'd like to welcome Dr. Jill Hinton and Ann LaForce, who are going
Hello.
to be here to answer some questions. I think they're going to begin with some reflections. Welcome.
Thank you. Thank you, Beth. Um, yes, while you can put questions into the chat and Beth will kind of watch those for us. But as Ann and I, obviously this was pre-recorded, as we rewatched it, I think both of us came up with some other things we wanted to maybe emphasize or re-emphasize from the training that we provided. So Ann, I think one thing that you had mentioned was just to kind of that reminder about underlying vulnerabilities and how we include that in any strategies we develop.
Yeah, I just think it's important to mention again and kind of emphasize that, as we talked about in our presentation, even before trauma or in addition to trauma, that people with IDD often have some of what we think more global common vulnerabilities around communication, executive function, and sensory needs, health needs. And so we just want to make sure we kind of emphasize that those things really need to also be considered, because they've probably been exacerbated by the person's experience with trauma too, right? So, but before we start thinking about any type of intervention or strategy or support or treatment, we want to take into consideration those vulnerabilities and make sure that we are supporting them, whether it's through some type of adaptation, other types of strategies that are kind of the strategies before maybe trauma-informed strategies. So, a good example would be somebody that really has some limited functional communication, particularly when they're stressed, right? So we would want to think about how do we support that person in being able to communicate both receptively and expressively the best that they can, while we know we want to try maybe some grounding strategies or other things that we talked about in the presentation.
I think that point came out yesterday too, with some of Karen's sharing with us some cases and recognizing. I think she mentioned somebody with autism, and one of the case examples we had yesterday is that having autism and having maybe sensory differences, communication differences, that just having those things can create trauma for folks as they're trying to navigate being in school or navigate a job or navigate the community. So that's a critical part of the trauma-informed work we do, is to recognize what vulnerabilities are already there. One thing, as Ann was walking through, and you did mention it, Ann, as we were walking through the triangle you presented with the regulate, relate, and reason, which we'll definitely come back to later as you guys work in groups later today. But just to reemphasize that regulate part is the bottom of the triangle. It's the biggest part. That can sometimes take a long time. And so us being very patient through that process is really important. It reminded me, Karen and Ann and I all have mentioned Bruce Perry several times, but reminded me of a story in one of his books where he had somebody, I think a teenage young man who came to, he has a trauma treatment center, who came there for trauma treatment. And I don't remember exactly, but he had some horrendous things that had happened to him as a child and growing up. And his presentation was really externalized, keep everybody away from him as much as possible. Nobody could get close to him without him being physically aggressive or throwing something, or so just really very scared, frightened, afraid somebody's going to hurt him. And so when he first came to be there, they weren't sure how, staff were really struggling with how to interact and how to get him engaged in any of the activities that they had as part of the treatment center. And what Bruce Perry ended up suggesting was that they not try to engage him in those activities. He was not at that point. He was in that regulation part, right? So he wasn't ready to relate to people. So he basically assigned him to a guy who did some maintenance on the property, and he was painting a really, really long fence. And so they gave this young man a paint bucket and a brush, just gave it to him, didn't make any demands. And he was shown to be out. He was outside with this other guy who didn't get close to him, just continued to do his work. And then the individual began to use the paintbrush, do some painting, and over time, they were able to get closer to each other, right? So they spent days, weeks with this regulate part of him just having something to do, solitary, but feeling safe, right? He was in a safe place. And over time, gradually, the guy that was doing the painting was able to get closer to him. And that's kind of how they measured the success of what they were doing, as how many feet closer to him did he get each day. But it took a long time was the point, and that we really have to think about giving people space when they're in that dysregulation part. And as we talked, the other thing that kind of resonated with me is we've talked a lot about skills and strategies, and the skills and strategies we're teaching are often to ourselves, right? We're teaching ourselves the skills and strategies we need in order to not re-traumatize somebody. So it's not about teaching that person something right then. It's about teaching ourselves how we interact.
And I think another point about that parallel, and Jill and I didn't mention it, but Jill and I often, when we talk about these kind of strategies, is like Jill just described, sort of being present parallel, but it's also really important, just a good strategy, that we remember that people that we're working with are in a heightened sense of scanning for danger or reading danger in things that probably aren't dangerous in reality, right? So our physical presence, we have to be very mindful about that as well, because if somebody is in that hypervigilant state and can see things as a threat, if somebody is in their physical space, if somebody is directly in front of them or very close to them physically, again, this is not a conscious thought, right? It's a physiological response from the brain. So if you unintentionally put yourself in some personal space, I've learned this from personal experience, and maybe like make eye contact or get a little too close as you're kneeling down, trying to be on someone's level, if they're sitting, you may end up getting pushed or kicked or, because again, you are in that person's personal space and their brain is telling them that that's a dangerous thing. So when we say parallel, we're talking about connecting sort of that parallel, but also physically, I think it's important sometimes to think about being parallel to someone so that they, even if you think like there's a clear escape route, right? So if this person becomes overwhelmed by your presence, and you aren't able to sort of move yourself, away quickly enough, that person can get up and move away with a clear path in front of them. So just also wanted to mention that sometimes we also mean that literally sometimes is,
Right.
Do not physically place yourself in front of someone if possible. And I just wanted also one more quick comment. I was thinking when you were telling those stories about trying to engage someone when they're in that regulate, I mentioned that, right? That these are strategies that we've talked about in the presentation that can be used really at any time for someone who is experiencing that overwhelmed sense that their executive function is not able, to be used in that moment. But we want to think about, like, we always want to keep people regulated. And so even as we are moving, I think I mentioned that right in the presentation, that even as we move the activity of the brain, we still want to try to keep that regulation going, because like Jill said, that's the kind of the phase or part of the brain that's going to take the longest, and the place that a person with trauma will revert back to is as quick as the stress, starts to come back. And I think about that, like if you think about other treatment strategies, like with younger children, like play therapy, right? A lot of that is to engage somebody in a task that does not take the thinking part of the brain, putting a puzzle together, doing a craft, some of those grounding kind of strategies. You can still do those things with somebody as they start to get into that more relate. It's kind of like you're kind of like building on your strategies then by keeping that regulation happening even as you start to move. And I don't think I said that very clearly in the presentation, but it occurred to me again listening to Jill talk about the kind of the painting the fence story, is that we're able to relate with people quicker if we sort of keep that regulate part of the brain busy with a soothing task as we do it.
And sometimes building those repetitive or soothing tasks into a person's day as a way to prevent some of the escalation, crisis, the trauma response. So I was thinking about a guy that I once consulted on, and he was in a day program, and had real difficulty with transitions from one activity to the next, or they actually had to move sometimes from one room to another room. And he loved basketball. So we ended up having him dribble a basketball from activity to activity, from room to room. So he would be going down the hall, dribbling a basketball from one place to the other. So it kept him calm. It also kept his hands busy. So he wasn't, reaching out and touching other people. But yeah, so I think you're right, Anne, those things, part of a therapeutic environment continues to include those regulation skills and the rhythmic activities, repetitive activities that we all find soothing, right?
I'm kind of laughing
low
right
music, a low beat that kind of goes like a heartbeat, like in the background, like those kind of things are soothing for us all.
I'm saying I'm kind of laughing because I'm thinking about the fidgets, like what a big thing, the fidgets, those spinner things, how many people use those. Well, that's exactly what we're doing, is we're kind of keeping the lower part of our brain that needs a little stimulation and regulation so that we can actually go ahead and access the higher parts of our brain. So I mean, we all do it. We all regulate ourselves in different ways all throughout our day. So I think that's a really important point, Jill, is thinking how we proactively build those things in.
So I think there was I saw one question around, in a really emergency situation where you're worried that somebody is going to hurt themselves or hurt somebody else. And certainly from the STAR perspective, we're always seeking to not put our hands on somebody or restrain somebody in any way, right? That's our goal, is to not have to do that. But we also recognize that if there is a situation where somebody might be hurt, that sometimes that has to happen. And I think the same things that Anne said about not talking to somebody at that point, in terms of rationalizing, right? Trying to get them to reason at that point, is important, because I think even if that has to happen, and again, that's not what we want to happen, but if it has to happen, using some of that calming voice, not talking somebody out of it, but using a calming voice of, we have to be, this is a safe space. We have to be safe. You're safe. Using those kind of words, not if you're still for a few minutes, I'll let you up, or don't, or remember that you have this coming up, or why did this happen? So none of that talk, but that soothing voice, even if you have to do that, I think is important in terms of that trauma response.
I do have a couple of other questions. So Dayashla asked, how do you implement these skills virtually as far as de-escalation, if being in person isn't an option?
Very good question. And I bet in our breakout times this afternoon, some of you will come up with some great ideas. But and Anne, you probably have some things to add to this too. I think as a START program, we really are a systems team, right? So ideally we could be in person, and I think for our crisis response particularly, that is something from the START perspective should always be in person. We know that that's been interrupted now by COVID. But so I think trying to figure out who in that person's system or current environment would be a good person for us to kind of work on developing some of these strategies so that we could talk with somebody else through implementing some of the things we just described, would be one way to approach it. And again, as we've talked about, trying to build in some of those preventive things, but in an emergency situation, having planned ahead of time, using our crisis plan to have these plans in place to work with somebody within that setting, I think is going to be key to how we approach these.
And then there's certainly times, even before COVID, where, from a START team might have a phone call that you need before we can even get there in person. We need to try to help support with some grounding, some soothing. And like Jill said, either really tapping into a person in the moment to kind of be the physical presence while we're talking through it, or even with the person themselves. If for some reason someone's not around, it happens, right? They maybe not have someone right there with them. Knowing that person and again, are they able to use their voice in ways that they can walk along with you in a grounding activity, a visualization activity, or us using our voice to be able to do that. And granted, we can't see the person, so we're not going to be able to tell, physically, if we can start to see some of that shifting, but at least being able to try some of those strategies if we are not able to be there right there, in the moment with a person, or have someone else to partner with. It does work. We've definitely seen it through some of our start crisis response, but always the ideal situation is to be able to be present. So I think, again, going back to the systems work and really wanting to partner with people that are around the person day in and day out, so that these strategies can be utilized proactively and in the moment. But yeah, I'd be interested to see, as you do your activity, like Jill said, some ideas maybe for how to do some of that if you're not able to be personally with the person in the moment.
Wonderful. Thank you. Another question from Laura. How does this work when 911 calls result in the opposite of, of trauma-informed care, but families are often advised to call 911 emergency services? How do we interact with that as START teams?
You want me to kick that one off?
I'll jump in.
Yeah. So, my first kind of thought is, obviously if START teams involved, we're really working with the family to try to minimize and give other strategies to calling 911. But in the moment, if that is what has happened, again, even if 911 has been called, if we are able to be there, then kind of using the police as part of our system, right? And if we can engage them in kind of describing what is going on with this person, that this is what we really think is a trauma response, and here are some strategies that we know have been very helpful. Most of the time, the police would rather do something like that, if possible, than have to take somebody, to an emergency room or somewhere else. So, hopefully teams have been able to build some relationship with police departments, but again, that partnering in that moment to give some foundation about what is going on with this person. This is a trauma response. We have some great strategies that can work and really help to resolve this in a positive way. With the START team I worked with, we once had a crisis intervention trained officer, CIT officer, who was able to respond to one of our individuals who spent 45 minutes walking around the house in circles, because the coordinator was going to take well over an hour for the on-call coordinator to get there. And she was able to talk to the police officer on the phone and said, walking really soothes this person. And so this officer spent 45 minutes walking laps around the group home and pausing every once in a while saying, "Are we ready to sit down and talk?" And he would shake his head no. And so they would keep going. So, that's a really fantastic example of when we can engage and get people, kind of on board with these strategies. So, Jill, what are your thoughts?
No, I agree. I was thinking that if a lot of systems have gotten used to calling 911, that's been the tool they had. So we do want to try to interrupt that when it's not necessary. But I think you're right in that's part, again, of our systems work, is how do we work with the responders that are in the regions we're working in to see if we can alter that to some degree in terms of their response to make it less traumatizing for everybody. And as you said, I think everybody wants it to be less traumatizing, not just the individual.
Mm-hmm. Also, just thinking about, if this is someone that, even if as we're doing the work, because we know change takes time. And so if it's somebody or a family, group home, whomever that is still calling 911 pretty regularly, if you're able to connect with that police department, sheriff's department, whoever responds, and kind of give like one of those little one pagers about who is this person, of course, with everybody's permission, and some about who they are and what causes some of, maybe the challenges in their day, and some really positive strategies, that has also been very successful. Because again, police don't necessarily just want to come and take someone to jail. If there's a better solution, a better outcome that's available to them, often want to take that route. So it might be something that you have accessible, or even something that is put into a system, the 911 system. Sometimes you can get people or addresses flagged. So again, some of that proactive work in the systems work can really go a long way when that crisis does occur.
Excellent. Thank you. This is a great question that sort of ties in culture. So the question is again from Laura, who was wondering how you might navigate cultural habits of both staff and families. And for example, different families might have different feelings about discipline, about information that they choose to share with service providers. So how would you go about navigating some of these cultural differences?
Around, so related to understanding or grasping or beginning to talk about some of this being a trauma response as opposed to being
Yes,
kind
let's
of
do that.
behind,
Yeah.
yeah.
Mhm.
Is it being a behavioral response? I, I think again, the way we work with all the systems we work with, trying to reframe where things are coming from. But I think before that, even establishing a common goal with families. So generally, even if we disagree about how we get to the person being happier, having less outbursts or whatever, that if we can all agree on where we want to go, that we would like this person to have a more calm day, that we would like there to be fewer outbursts, that we would like them to smile more. And, so if we could come up, to me, kind of starting with identifying where we want to go is sometimes the first step rather than just coming in and reframing, right? So that you have something you agree on to start with. That's often how I start when there's differences about how to get there. And then you can begin to back up with that and give some examples of positive interactions. And again, we, beginning to engage with families too on, let's, like we talked about, what are strengths and what are positive things, because a lot of times systems, families are used to providers coming in and just asking about all the problem behaviors and what's going wrong and how do we fix those. So even beginning that can shift it a little bit, and again, kind of agreeing on where we're going, to me is a good starting point. Anything you want to add to that?
No, I was just thinking, and again, more of a kind of a systemic strategy is when you can agree on, whether it's cultural differences or just parenting differences, whatever the case may be, being aware of that and being sensitive to that sometimes it almost is a little bit of like, once you've kind of got that common goal, and we might have some strategies we want to introduce or ideas, and the family might be like, that doesn't fit with our approaches or our beliefs or our values. So we want to, it's almost a little negotiation, like, okay, so could we maybe just try this as a way to begin? And so I think we have to be very flexible and very willing to keep that common goal in mind, but be very, very flexible, I'll say again, in how we might approach getting there together. And sometimes it's very much baby steps, and we have to let people have the time to trust us as well. And so that's not going to happen if we're not culturally sensitive, even if it's their family culture that we're taking into consideration, that if we're not willing to hear that and adapt our approaches, then we're not going to be able to build trust. And if, when you build trust, then there's a lot more options that can happen. So I just think that's an important aspect of it too.
Well, and it reminds me too that we're, again, working with systems, working with families, and we're recognizing just those questions too about everybody. People are coming to us because something has gone wrong, and thinking about what happened, not just to that person, but what's happened to that family, and where's that family coming from, and how do we move from what happened to that family to what is right with that family. So thinking about the whole system from that trauma-informed perspective. And the other thing I'll say is that when we're talking about a trauma-informed approach and the way that we approach everything we do, so it kind of undergirds everything we do as in our START program, right? So we don't have to go into a system and say, okay, now we're going to do a trauma-informed approach, right? it's kind of embedded. So it's demonstrated more than it's taught. I mean, we may do some training with the agency or the system around trauma-informed care and trauma, but on a kind of case-by-case basis. Sometimes we may do that, and sometimes you don't have to talk about it. But you can still develop strategies that use that approach. So I think I saw another question about, culturally of taboo subjects that some families don't want to talk about, and they're not going to tell you about bad things that have happened or abuse that's happened. And that's okay. Like Karen said yesterday, sometimes we don't know, but that doesn't mean it didn't happen, and we don't have to know. In order to provide a trauma-informed approach, we don't have to know what happened. We can do this anyway with everybody we support. So we don't always have to know those details.
Right. Which I think, I always try to, I think I said it in the presentation, is all of this stuff that we talked about supports executive function. So if you are working with a family or a system that either can't recognize or understand, that this is trauma, that's okay. Because we're going to support people's executive function, right? We do that work with everybody. So yeah, it doesn't have to be kind of pushed or forced that people acknowledge or recognize or talk about that there's been some kind of trauma, that we're still going to be able to introduce and try these strategies, because they're sort of universal approaches for people that whether you have ID or not, right? Some people, executive function is really what we're talking about supporting.
Thank you so much. I think that those were excellent points to emphasize. And both of you have recently talked about the importance of building trust and linking with systems, which made me think about the cross systems crisis plan, which we know is a cornerstone of the START model. So how does trauma-informed care relate to START's cross systems crisis planning?
You want me to start that one, Jill, or?
You can start it, because I think it flows through the whole thing, from the preventive strategies all the way through the end. Yeah,
absolutely. So that's what I was thinking immediately, going back to what Jill had said about, both of us had talked about those regulating types of approaches. So in addition to recognizing the underlying vulnerabilities, often think about our cross systems crisis plan being telling kind of a reframed story of the person, from the aspect of, where do some of the difficulties or challenges come from, and how do we support that person by understanding them better. So if we kind of use that lens, and it's trauma informed as well as biopsychosocial, then our crisis planning also involves proactive daily support of what we know are those underlying vulnerabilities. And so we would build a lot of these strategies into our stage 1, right, which is our very early warning signs. We don't want to wait for somebody to have a problem or experience a crisis. We want to get in there proactively. So putting these things in place, and then in stage 1 of our crisis plan, really teaching people to be very aware and start to learn those early warning signs. If I sit and I kind of start to rock a little bit, or I start to hum under my breath a bit, I'm going to know, like, okay, those are early warning signs that Anne is feeling stressed for whatever reason. So let's make sure that we have something that's we know is soothing her, calming to her. And so building those things in, certainly from a proactive standpoint. But then as we work through sort of the stages of crisis, we're sort of working our way down that Bruce Perry triangle, right? So early warning sign would be up where we're still can use some of that thinking, feeling part of our brain. And as we go more into the stage 3 crisis, we're really now looking at regulating the brain. So if we think about that triangle kind of in reverse, as a crisis builds and escalates, that would be the way we would want to integrate strategies and supports into the crisis plan.
And often in that third stage, you'll see, have other people leave the space, reduce stimulation, reduce sensory input. You even do that some in the second stage too. But just like we talked about when Nan was talking about the regulation part, you're trying to just basically get that person to be in the here and now and take away other distractions that are out there that may be at that moment, because they're so dysregulated, any of those can be traumatic for them. Lights, sounds, people. So trying to reduce that is a way that you're trying to approach the brain where it is when somebody's in that stage. So that's a great question, Beth. I think that definitely feeds into the cross-system crisis plan. One thing, well, we still have a few minutes. One thing that I think Ann mentioned this in her talking about strategies, is that sometimes folks are receiving really specific trauma treatment, and there are some evidence-based trauma treatments out there that have some evidence for people with IDD even. So we mentioned Trauma Focus CBT, we mentioned DBT, or some of Julie Brown's work, which I know a lot of the programs use some of her skills regulation type activities to work with folks. And then EMDR, which is showing more and more evidence that is a really good treatment. And I think that's something Karen Harvey uses a lot in her practice, is EMDR. But Ann and I were thinking about those, those other trauma treatments that people might have access to. And from the START perspective, kind of evaluating those from the perspective of the 3 A's. If we think about access, appropriateness, and accountability. So as you're thinking about in your communities, if first of all, is there EMDR happening in your community? Are there therapists that are doing trauma-focused CBT? Is that even available to start with? And then appropriateness to think about, are there therapists who actually have some background in IDD or have an openness and willingness to work with folks with IDD, so that, as Ann mentioned, sometimes these practices have to be modified a little to meet the needs of the folks that we're supporting. So thinking about that part of it too. And then, we want to make sure that there's feedback and ongoing work together. So kind of that accountability. Any of these practices should be then linked back to the bigger interventions, the bigger support strategies of how this person's being supported. So we know, especially something like some of the DBT skills are most effective when there's a link back to where the person lives and works and every day, so that these things can be practiced. So kind of using those 3 A's to think about that. In terms of some of these practices like trauma-focused CBT, you really have to think about that individual in terms of the appropriateness. So that requires more verbal skills and a retelling of stories. That also requires a supportive home environment or living environment where somebody is kind of partnering with you to talk through trauma. So that might not be appropriate for some people. So really thinking, I think we want to give people access to some of these specific treatments, but really think through, it's not just whether they're available, it's whether they're appropriate, because we don't want to re-traumatize people. So that would be the worst thing, is to say, we have access to trauma-focused CBT, that's the only thing we have in our community, so we're going to send somebody there. But if it's not appropriate, it could re-traumatize somebody. So really thinking through those 3 A's and evaluating practices that might be available for folks.
And I think a couple points to add to that is thinking back to something I mentioned at the beginning about, like, how does all of this sort of relate to some of our practices of START, right? So thinking about therapeutic coaching, which of course therapeutic coaching would be fantastic to practice any of the strategies we've talked about today. But in thinking about how systemically connecting, so if somebody is, working with a therapist around supporting some strategies, through DBT or EMDR, or whatever the case may be, how do we also help support that? So systemically, we want to be able, START coordinator, others, connect with the person who's doing that treatment, sharing our knowledge, getting knowledge from them. How do we incorporate that into our work? Maybe we use therapeutic coaching to help practice and support that the person's system in utilizing those strategies and building those skills. So again, we kind of want to create a bridge, right? And the connection to any community provider, because sometimes that is what it takes. certainly worked with lots of different types of therapists who did not have a lot of experience or expertise working with people with IDD, but they were willing to work with the START team and try some different strategies, even if it was just modifying how much language they're using, right? Or how people do homework after sessions. So we want to also think about how we help build capacity in our community providers too. And then just wanted to mention one thing, because I still hear this. I'm sure, Jill, you do too. I think we talked about it. Some of the myths around trauma treatment. I remember I used to work with kids in the community, and I heard a lot about how children or people could not receive trauma treatment until they were no longer experiencing trauma. Well, you will continue to experience trauma until somebody recognizes that and helps support you in healing from it. So, like what Jill said, like the environment is important when we think about the approaches that we're going to take, but we certainly wouldn't not try some of the things like we have talked about today, on a daily basis, to support someone, even if they are living in a traumatic environment or continually reliving their trauma for some reason. So I just wanted to say that, because I still hear that sometimes with trainings. I was like, well, what do you do if a young person or adult is still living, in a neglectful or an abusive environment that we're working on getting them out of? Well, all the more reason why we really want to try to help support them and build some resiliency then. Okay, more questions for us, Beth?
There's one from S. Bryant. For people with IDD who have limited language abilities, especially when face to face, but do lots of self-talk when alone, do you have suggestions as to how to encourage language opportunities when they might be able or ready to share parts or major pieces of a traumatic event?
Well, I go back, I think, what Jill just made a good point about is that we certainly don't need them to share the story, but if they are ready and wanting to, because that can be a very big part of people's journey to wellness, there are a lot of different types of expressive therapies and other ways that people can express their experiences, their feelings, that maybe don't even use words, right? So again, I think that's an individualized thing of what might interest that person or what they'd be able to. But I think there's lots of great strategies that a person could express their experiences without actually having to use words.
Yeah, I talked to Karen yesterday after our training about some of the EMDR work she's using and using with folks, and she had said that she's used it with folks who have very limited language ability, but there was some knowledge of some traumatic events that had happened, so they didn't have to say it. She could use symbols of it or words that reminded them of it as part of the EMDR treatment, and was able to do that really without having to retell a story. So I think there are ways without having to make the person tell the story. Now, like Ann said, I think that all depends on whether the person is trying to share it with you, or maybe the self-talk is just the way they're dealing with it right now, and that's okay. We can still do trauma-informed approaches, even if we don't know exactly what it was. And just them saying it saying it to another person, if they're not ready, might make them feel even more vulnerable. So I think it's a really tricky place to be. But I think the key part of that regulate is to make sure people are safe. So the more you don't stop them from the self-talk, you let that happen if it's not escalating them. And even if you hear that happening and can even use soothing words after you hear that happening, I think to more kind of reinforce that we're here to help, reassure. They may share with you, but if they don't, it's okay. We can still treat trauma from that perspective.
And if you think about sort of the cognitive restructuring kind of aspects of cognitive behavioral therapy, for places that have resource centers have probably seen this happen when counselors do some things that are just really awesome and organic. And it's really about, I think, building that positive identity, Jill, that you talked about. So I'm thinking about a particular young woman that would often say things under her breath. Sometimes she would be by herself, or she would just, it was almost like the scripted language that we learned very quickly that means she's stressed. And she had had a history of trauma, a lot of verbal abuse, clearly, where some very horrible things had been said to her. And she would start to repeat those things. And once we recognized that that's what that was, of course, that's not necessarily perspective of her providers, when she would curse and say things, but we recognized that that was a trauma response. And so when we would start to see that happen, just like Jill said, do some very soothing, grounding types of things. But what we really dug into was some of the positive identity. So we did a lot of this great activity called Flip the Script. And so again, during times where she was happy and calm and in that thinking brain, we would use this activity for her to take negative statements, and we kind of made them a little closer to not exactly things she said, because we didn't want it to kind of trigger her, but closer to some of the topics that she would repeat that had been said to her over her life. And then we would do the flip the script, where we would then turn it into a very positive, self-loving kind of statement, right? And so got to the point where we practiced that with her, that then you were able to, as she started to do some of that self-talk, some of that scripted negative language, introduce a more positive statement and get her to start listing positive, like almost affirmations, right? So some of that, again, is changing the way that brain works from all that negativity and hurtfulness that she had experienced. By building skills at the right time for her, able to start changing that even in moments of stress, where we saw less and less of that negative stuff. And then she would start to tell people, like when she would start to get stressed, she would come up to you and say, I'm a good person, I'm a good friend, and start to use some of those positive statements, which was really lovely to see. So again, thinking about that brain and how powerful it can be, and how we can use some of those strategies to help changing the way that it ends up getting presented for people.
And for those of you who know much about EMDR, that is really comes pretty much right out of there in terms of part of EMDR is installing positive cognitions instead of negative emotions, negative cognitions. So yeah, like we said, a lot of these things come directly from some of those evidence-based practices.
Well, thank you, Dr. Hinton and Anne, for this thought-provoking question and answer session. And thank you to all of you who submitted questions. I hope that we have answered your questions. We are going to move into a break now. We are going to have a 30-minute break. And when we return, we're going to review a case vignette and then have some breakout sessions and discussion. So thank you very much. And we'll be back in a half an hour. You can stay logged in, muted with your camera off.
Thank you all.
Thank you.
Thank you.
Hello, this is Pam Gillespie. Oh, good, good, good. Yeah, just I just am taking a break. We're doing this START orientation training, so. Sorry, for whatever reason, this thing went back on mute again. Yes, which Jennifer was in contact with me this morning to let me. I do not know.
Okay, welcome back, everybody. The time is now 3:30 Eastern, 12:30 Pacific. Hope you all had a nice break and were able to get up and stretch a little bit. I'd like to welcome back Dr. Hinton and Ann LaForce, who are going to share a case example that will lead us into our breakout sessions. Just a quick note that a copy of this case vignette is in today's session guide. So now would be a great time to download that session guide, as well as the FAQ guide, which is going to give you instructions for our breakout sessions, which are coming next. All right, welcome.
Thank you, Beth. Welcome everybody back. Looks like we've got most folks back. So what we'd like to do is to use, this will look familiar if you pulled up your vignette. What Ann and I decided to do was to have kind of carryover from yesterday. I think most of you that are on this call were on the call yesterday, the meeting yesterday. So we're going to continue to talk about Gina, who was one of the case vignettes from our discussion yesterday with Karen. So I'm just going to remind you a little bit about Gina, and then, we wanted yesterday to really identify specific events that were traumatic for her. So we tried to lay those out, but I'll just remind you a little bit about her, and then we'll talk about what we want you all to do as you break out in smaller groups. If you remember, Gina's a 21-year-old with mild intellectual disability, and she was presenting and probably likely would have been, referred to a START team. Let's think about it from that perspective, due to verbal and physical aggression in her group home. And that was becoming really troublesome for her staff, and there was a lot of conflict with the staff, and the staff weren't always handling things in the best way. If you remember, there was 2 or 3 examples of times when Gina became really upset, and it resulted in emergency service use. One of them was when something was being served for dinner. It was not something she wanted. She became really upset about that, was verbally aggressive. And there were arguments between staff and Gina, and they said she was spoiled because she wanted to have what she wanted to have, not what everybody else was having. And anyway, it eventually ended up in her hurting one of the staff. There was another example of when she thought her mom was coming to see her or to pick her up or to visit, and her mother didn't show up. And if you remember, Gina had kind of a had been with her mom early in life, had been taken away from her mom, and then back with her mom at some point in life. And then there was another incident where one of her housemates returned from a trip with her family and had a small stuffed animal that she was showing people, and Gina grabbed it from her. And then again, this resulted in an altercation. So just a few examples of what would happen when Gina became upset. So as you all worked yesterday in your small groups, these are some of the things that you identified as potential trauma experiences for Gina. You all, identified that her mother, it reported that her mother had experienced substance use disorder very early, from the time Gina was born till age 4, when she was removed from her mother's care. But the question came up was, was her mother using alcohol or other substances before Gina was born? So we talked about the fact that exposure to alcohol in utero can certainly have an impact on the developing brain. And specifically, in utero exposure can cause differences in the way the cerebral cortex develops, and particularly the frontal lobe. And if you think about what we just talked about with the brain and executive functioning, that makes sense. There's also affects the corpus callosum, which is kind of is some people describe it as kind of the super highway of learning, because that's the part of your brain that connects the left and the right side. And it could be impacted in terms of understanding cause and effect, learning from what you've experienced. And those are the kinds of things we see in people who have fetal alcohol spectrum disorder. So that's a possibility of a trauma that happened early. As a very young child, and this was before the age of 4, she was sometimes left alone. and her mother didn't return home and was not with her. So thinking about that from a child's perspective, remember the 3 E's of an event happening, the experience that the child has, and the effects of that. For a 4-year-old of, being really fearful. And so that sustained fear response can definitely have an effect on how the brain develops and how it processes things. And then that attachment that needs to happen in terms of being taken care of really early in life. And then removed from her mother at age 4. And again, we all know this, no matter how difficult that situation was and how neglectful it was, being removed from your parent is a trauma. And it could be feelings of abandonment and really that loss and grief that can be a result of that. We didn't have a lot of information about foster care, but she was in foster care from 4 to 15. What most of us know about foster care is often that's not one place. That's often multiple places that people get moved from place to place. And knowing her history and the way she's presenting now, we could probably assume she was in several different homes. We do know she received special education in school. That was noted. And as Karen kind of laid out yesterday, just thinking about the things that happen because you have IDD, of not feeling like you belong, being isolated. A lot of people are bullied in schools. So adding to these traumas. She was able to reunite with her mother at age 15. But from what we understand, there continued to be conflicts and maybe some re-traumatization. Some of you brought up of, were they living in the same place or a similar place? Was she triggered from some early memories from childhood, or just triggered from interacting with her mother? And again, we didn't really talk about this yesterday, but thinking about how that bond can be rebuilt in some way. I mean, that's a terrible thing to lose early on, is that connection, and then to be reunited, but then for it not to work out is also another loss, right? So another trauma. And then moving to this group home just recently at age 21. So again, new people, re-traumatization. So Gina has been through a lot and had a lot of things happen to her in her 21 years. Some things that we didn't talk about yesterday is that Gina, she's not 24 hours a day being externally triggered and, being physically aggressive with folks. So other things happen with her. She often spends time in her room by herself. And when she does, a couple of things, she has some books and journals. She likes to write little notes and write people's names in this notebook. She does like when she can have access to like craft materials and things like that. She likes to make bracelets with little beads, and she can spend time doing that. And she sometimes gives these to people in the house or to people she knows, or she'll leave them for them somewhere. And she does like to listen to music too, is interested in several different kinds of music. So again, that's kind of a recap of Gina and what we know about her. And you all will remember some of the things we talked about yesterday. And again, we were just trying to kind of outline yesterday what these life experiences, traumas were, and how they may have affected her and are showing up in her current presentation. So we want to use this one then to kind of apply it to what we talked about today. So Anne's going to kind of walk through the questions for the breakout and what we'd like for you to, we'd like for you to think through Gina's example.
Mm-hmm. So reflecting back on our triangle, Bruce Perry's triangle here, I want to use that as kind of the model to utilize during your breakout session. And as Jill just described, Gina's had a lot of unhappiness and stress and trauma in her life. And so thinking about those times where that has become very externally present for her, right? And so how might we take some of the information that Jill and I covered today earlier and develop some strategies, some support strategies for Gina during those times of stress. So we want you to consider the impact of those life experiences that Jill just kind of outlined on Gina's development, including her, the biopsychosocial, physiologically, psychologically, and socially. And then for the second part of that then is utilizing your breakout time to identify and describe those vulnerabilities and strengths of Gina, and utilize this triangle, Bruce Perry's triangle, to discuss and describe some of the strategies that you might want to try out, to implement, to help Gina move the activity of her brain from that regulation place to more of a thinking, feeling, reason, and relate place. So that's the activity for today. And we'd really like, hopefully everybody will have time to come up with some good strategies for each of those levels, and thinking about, why you're thinking about certain strategies and how we think it can help to move that activity of the brain from very reactive place to the more thinking, feeling. So that's task.
Yeah. I would just say too, so, as you think about regulate, relate, reason, as you get to reason is when somebody's, maybe using their thinking and feeling brain together. So in the moment, we want to get people to that point. So strategies kind of in the moment when somebody's dysregulated, but also in that reason area, you can also, if you want to, come up with some things like we talked about that are prevention almost. So what are other things that you practice work into people's days can be included in that reason part also.
Right. So that thinking brain learning opportunities, right? Okay. And we have, you have, is it a half hour?
I think that's
Yes, a half an hour.
right. So Beth, you're going to break folks out into rooms, and like yesterday, come back prepared to share, and we'll hopefully get to as many people as we can.
Yes. All right. So here's a few more technical instructions. So we already talked about the fact that you have 30 minutes. I do just want to note that if you need live transcription, you can either go into your breakout room and choose to leave the breakout room by clicking the leave button, and then it'll show you leave breakout room and select that. Or when you get the pop-up box that says join, there's also a button that says later. Just click later and stay in the main room, and that will enable you to be in the room that has that live transcription. Okay, so when you enter the breakout room, this is an interactive experience. We want you to engage with your colleagues, so turn your camera on. You'll want to identify a discussion leader. This is the person who's going to read the prompts out loud and keep the discussion going. The note taker and reporter is going to be the recorder of the group, and they're also going to be the one that volunteers to report out on behalf of the group during the large group discussion. And you might also consider identifying a timekeeper. 30 minutes goes by fast in a breakout room. You will get a 1-minute warning before your breakout room closes automatically, but that can sneak up on you too. All right. And then, as Jill and Ann said, when you return from the breakout room, we will check in with our groups, and we will do that by randomly selecting group numbers. If you have any issues when you're in your breakout room, and this includes not being able to turn your camera on or unmute yourself, we know that for some reason that happens sometimes, click the Ask for Help button and the bottom bar, and you'll get someone from CSS that can come in and help you. All right, we're going to send you off to your breakout rooms. Look for the pop-up on your screen that should say join, click it, and good luck.
Hello.
Hello.
Okay. Make sure I can be heard today. Yesterday I had a hard time.
Oh, good. I'm glad.
That I had a hard time.
We're glad we can hear you and you can hear us. There you are.
There I am. I'm trying to print out the information. I didn't do it at break time. What can I
Excellent.
say?
We're all juggling a lot here. I understand.
Oh God. So, okay. How many people we have?
Oh goodness, we had well over 200 today, Lauren.
Oh no, I meant on our group.
Let's see, who do you have?
Excuse me, I need to go into a room to help out. I'll be back.
Okay.
I can keep my own time.
I was summoned.
You were summoned?
Does anyone need any help in here? Yep.
Yeah, hi, this is Jeff Weitz, and the host has stopped me from sharing my camera.
Oh, okay, so that is me. Let me see what I can do for you.
Oh, I did that.
Daniel, did you say you were going to be the timekeeper?
Yeah, that's not a problem. I think
All
we'll
right,
be done at
Jeff.
1:15.
Okay.
All right, is everyone else all set in here? Okay, thanks for calling me.
All right. So
right.
like I said, I'm gonna mute myself and go off because I'm gonna have to hop around here. So I'm gonna leave you all to it.
So what's our first question?
Um,
And those are a lot of books.
oh, you talking about my library?
Yeah, right, right. You better hope you don't have to move anytime soon.
I hope I don't what?
Have to move anytime soon.
You haven't said nothing. I just need about a week to get them all packed. That's all.
There you
I
go.
don't know. Let's see, our first question. Everybody has the printout. I think I had the printout correctly. I'm not sure. Are we supposed to use the, or we just have to use this part of the case vignette?
I think so.
Yes, yes. Today's vignette. Yep. But
Okay.
Gina.
Oh. We can do this one easy. Did anybody want to be the person to write down our suggestions so they can present it at the end? Try not to have everybody all raise your hand or speak up at once. We don't want to overwhelm our little site here.
Miss Lauren, hi.
Hi, Michelle. Did everybody read it yet?
Is this Gina we're reading?
Yes.
Questions for breakout group discussions. Describe vulnerabilities and strengths of Gina.
Yes.
Yes.
All right, so we basically got a summary above that.
Yes.
All right.
They just list her life experience, her events and life experiences, the trauma that they see. And then we have to consider the impact of these life experiences on Gina's development. So physiology,
All right.
physiologically, psychologically, and socially. So I guess we hit each one of those for each. We have to give three, provide at least 3 for each case example.
Well, it's one case example, right? Just Gina's.
Right.
Yes.
All right.
Well, I think one of her strengths is clearly resilience.
Okay,
That stands out.
resilience.
One of her vulnerabilities is low self-esteem.
Did you when for each one that you give, can you give a little bit of why you gave that?
Sure. For the low self-esteem, she was removed from her mom's house at the age of 4. She was left alone a lot. I'm sure she was feeling that she kind of did something so that mom just kind of left her by herself, which caused her to have low self-esteem.
Are you talking about neglect
Yes.
and being in the foster care system?
So maybe
Yeah.
just attachment disruption.
Yeah,
That'd be
okay.
a way to summarize that.
Mhm.
As at this point, it would be reactive attachment disorder. That would probably be one of her vulnerabilities. When a child is at, you said she was removed at 4 years old. When a child is moved, separated from their primary care person, and then at an early age, they have no permanent primary care person, etc. It can cause that it shows up as reflective attachment disorder. They used to think that you only could have that if you were small, but now they know that it can show up later in life.
So that's a label, but it's not, what does that mean?
Right.
Okay, you're saying if we just give a label, it's not
I mean,
really.
we're given labels like saying one of a person's vulnerabilities or weaknesses is their diagnosis with attention deficit disorder. It's just a label.
Strengths. Hi, host. Well, I think this is 3. Oh, I'm gonna let her.
Hi.
Hi. So we can hear the ticking of the clock counting down the seconds and driving us all insane. Could you help us?
Really?
Yes, please.
Now this is a first.
At least we think that's what it is.
Yeah, that's what we think it is.
Okay, I don't know how I would stop that. Let's see.
Can you hear it?
Okay, I can hear it too. Okay, let's. And it is in sync with my clock.
Yes.
I don't know how I would stop that. I will leave the room. I will go into the breakout controls and I'll see if there's anything I can do, but I am so sorry.
It's like a metronome.
A mute button would be awesome right now. For the clock only.
Yeah,
mute the clock.
I am muted as the host. Well, I'm not muted now, but I was muted while you guys were in the room. So I will do my best and I'll come back in a minute or so and see if it's still.
Thank you.
Thank you, Anne Marie.
You're welcome.
I didn't hear it in the main speaker, so it could potentially be one of us. It's depending. Maybe if we all mute and then unmute when we are speaking, maybe that would give it a nice
Okay,
little
let's
chance.
try that.
Difficulty building relationship due to multiple placements and multiple providers throughout her lifespan. There's 3 vignettes, right? So we talked about Gina. There's also another case about John.
We're only doing
They
Gina
gave
today.
They
Oh,
only
just
gave
Gina
her,
today? Okay,
Yeah, that's all we've got.
okay.
Yeah.
So we
we
got a
can-
bunch of
lot.
vulnerabilities. We need to move to strengths.
Yes.
Yes.
Yeah.
oh,
So-
those are, okay, these three were for the vulnerabilities. Okay. Okay, and so somebody else said some of her strength was resilience.
Mhm.
Why are we saying resilience?
Well, because given her history, just still being here and still managing to be present at 21 years old.
Well, more objectively, she's not institutionalized.
Right, right. Yep.
Yeah, I would say she's very adaptive.
You say she is very adaptive?
Not very, but she's adaptive. I believe she's been in different like situations. She can if she gets the right assistance to help, she can be able to stay afloat.
So would you say that you're saying that she's resilient because she's made it, she lived up to 21, that she has, so because of being able to survive this?
Well,
Yes,
and
going
again,
through different changes through
right, to be in the community still, to make her way through all of these different placements.
That resourcefulness ties into that somewhat. We only had a vague amount of information about her upbringing, but knowing that she was on her own at 4 and probably left for significant amounts of time, she was able to survive, to find ways to keep herself safe, to eat, whatever she had. I mean, she made it through that. And then I don't know if this is an additional one or ties into it, but it talked about in terms of academics. So she's in a school setting. It didn't discuss problems with that. So she might have some academic strengths, or she might do well in like a structured environment. And that's just kind of going from that perspective, is didn't mention anything that was wrong or, dysfunctional in that setting.
That makes sense. It doesn't, in the vignette, it doesn't say that she was an out of school district. She seemed like in a mainstream. So she's definitely.
It says right here, she received special education in school. That means she would have been in a 75, Department 75 special education. But she still, she
seems to be successful within that environment.
Right.
I mean, didn't mention anything else.
Okay, one more. So it says, consider the impact of these life experiences on Gina's development. So how,
To the impact of these development and physiological. I think we just described those. We just
Well,
did.
I think that even the coping skills, she's not using coping skills that are good or appropriate. She's using verbal and physical aggression. But it really shows that kind of the brainstem that's fight or flight, and it's animalistic, and it's, so there is some coping mechanism there. It's not a good one, but it's there and she's using it.
Well, when you said, this is just a question, when they're talking about the impact these experiences have had, she's having a lot of difficulties. So would we say that she's having these difficulties because of her life experiences, and one of the difficulties is
All right, so now we need to come up with 3 for relate.
Hi, just checking in. Are you still hearing the ticking?
Yeah.
Yeah.
I can't stop it. I Googled how to stop it. I'm not finding anything. And nobody else has mentioned it, so it might just be your group. So this is a first. So when you share your Zoom stories around the dinner table, share this one. I apologize for the noise. I'll keep trying.
Thanks for coming back.
Okay, thank you.
Physiologically kind of stunted the way that her brain works.
To clarify,
Do you mean to put it a little more simply, do you mean does she have the capability to learn more adaptive and more appropriate coping skills?
Yeah, yeah.
All right, that's fine.
Yeah, did she have that ability at that point? Or is it kind of stunted?
So we would say that her history caused her ability to remove from the brainstem to the limbic has been stunted because of what she's gone through.
It could have been, yep, the potential is there.
you guys, to clarify, so are we identified, so 3 areas of concern, and then we identify 3 strengths, and then we are trying to then align it with what strategies or interventions we would use?
Yeah, in that regulate, relate, reason.
Okay. So do we have the 3 strengths?
I believe so. I think Lauren took notes: resilience, resourceful. I think what was the other third one? Resilience, resourceful.
Oh, was it an adaptable?
Adaptable. Yeah.
Okay. Okay.
You're saying that she's adaptable?
Well, I mean, if you've been and you know, if you're like in different multiple placements and you have new environment all the time, you have to adapt with the changes. And somehow she has done that.
Yeah.
So resilient, she's a survivor because of all the years of, being, the struggles that she has encountered. She's able to kind of live. She hasn't committed suicide. She's still alive and kind of fighting for a cause. And then being resourceful.
Oh, because I guess we could say she, even though has adapted and been resourceful and resilient, that's helped her survive, although it hasn't been on the positive side.
But I like what Jen mentioned, though. Yes, it hasn't been in a positive side. However, she has the skill. She has the capability, and it's just finding that moment of opportunity of teaching her the more
how to transfer that skill appropriately.
Correct. Yeah.
And I hello everybody. I'm sorry I'm joining late, but also to add to that is that she took the sensory, she took the animal, the stuffed animal, so she could use that as a coping mechanism. It's to soothe her. So she is able to adapt as long as you teach her. You ask for something instead of just taking it. That could be also used. She knows what she likes.
Yeah. Yeah.
So then if we looked at intervention, so then as far as like a soothing object, that's a transferable skill, it sounds like, that she has and that you're talking about. It sounds like we would want to do something to ground her because of her anger or aggressive outbursts. So whether that be like, it seems like at this point she's in that fight piece, and so there's that need to expel that energy. Or that buildup, and so maybe it's then transferring that into let's go on a walk or let's go throw a ball, but something that's physical. Let's stomp in a repetitive motion, something like that.
Are we now talking about the regulate part?
I jumped into that, sorry.
And
That's
I
okay.
think
I'm just,
Seems like it, yeah.
I think
Okay,
that's where we're at right now, isn't it?
okay,
seems-
let me see if I'm writing this down correctly. I don't want to misrepresent.
Well, thank you, Lauren, for volunteering and
I didn't volunteer. Y'all refused. Y'all stopped talking when I asked. So being the gullible one, I just kept started writing. I should have just sat there with the rest of you. Anyway, so we said her vulnerabilities were low self-esteem, difficulty with trusting. Have to make sure I can read this. Exposure to drugs and alcohol prenatal and predisposition. And difficulty with relationships because of multiple moves in the foster care system. Do I have that right?
yes.
Feel free to correct me now, because this is going to represent all of you for the rest of your lives now.
Not only for the next 3 days, not for the rest of our lives.
Nah.
Luckily, there's an inverse relationship between age and memory retention.
Well, then that means you really need to help me. Okay, and then her strength that you have down is resilience, has survived the different placements, resourceful, and like knowing how to spell and write. Resourceful. She was successful in school, in the school environment. Even though she has negative coping skills, you said it showed her. It showed her what? Hello? Help.
Well, I think it just shows that she has skills and she has the ability to use skills.
Okay, let me write that down correctly.
I would take the part about the school out because we really don't know how she did in school. All we know is that she was in special ed.
Yeah.
And because that was linked to resourcefulness, and the first part of what I had commented on is she survived long periods of isolation or being left alone when she was a child.
Okay, so for resourcefulness, we're saying that she survived what? Say that again.
We can just say she survived her traumas.
Okay. So resourcefulness survived her trauma.
And then an example of that, if they ask for more, might be she was left alone for long periods of time as a child and somehow fended for herself. We don't know too much of the details.
Correct.
Yep, that's right.
And sometimes I think, especially if you go on a crisis call or you just meet a person for the first time, my thing is you're just thinking about how you can help at that moment. So you just go on with what little bit of information you have. And even this is a lot for a child. Okay, so then you said you talked about we talked about the impact. And the impact is her history caused her brain to be stunted from the bottom to the limbic.
Yeah, there's a possibility of the brain development not having developed properly.
Right, and I would use that word that it, probably, because we don't know for sure.
Right, yeah.
So are we thinking that she probably is based still in the relate stage? that she may not have really been able to get there, or do we see where she has been able to get to the cortex? Maybe when you were talking about her ability to use her skills to take used her thought process to snatch the little stuffed animal to self-soothe.
I see her more in those bottom stages still. So mainly like in regulating and then relating, like really focusing on the regulating part first, because she was very easily triggered, it sounds like, over dinner and whatnot.
So she's still, so we're thinking that she is still basically in the regulate, going between a regulating and relate. Is that what you're saying?
I would say the focus of treatment would be on regulating. What would you guys say?
I agree. She needs to like regulate. Yeah.
You say she's still on regulate? You say she's still on regulate?
Yes, regulate. Anybody else?
Are
What
we
do you think,
supposed to
Joanne?
decide what stage she's in? I thought it was just, you know, do the strengths and the vulnerabilities and then have, you know, 3 strengths, 3 vulnerabilities, and then 3 items for each stage of the pyramid.
Yeah, I think that's pretty much it.
Yeah, I think we're
Yeah,
getting into a little
regulating,
bit too much
adapting.
detail.
Yeah, get
getting
that, and I think we'll be
too deep into this.
Yeah, yeah.
Oh, so are
We're
we,
not getting
did we
extra
cover
credit
it
here.
all? So
Well,
we're
not
covered.
really,
We're done.
because what they're looking for is what do we do in the regulate stage? You know, so at the regulate stage, you'd want to, you know, reassure, do the safety. Again, if the person is dissociated, you're going to do the grounding, which is using the soothing voice, the repetitive phrasings. I know a long time ago when I worked in psych, we would use the year that we were in to help bring them back to the present. And then what would we do
The 5
in the
senses, find something you can smell, that kind of stuff.
The 5 senses. Yeah.
Yeah.
Does anybody see the time on their screen? 'Cause I don't see it on mine.
Right now it's 4:13.
So probably about 2 or 3 more minutes.
You guys have about a minute left.
Oh, on the East Coast, eh?
I was gonna say, I'm way behind you guys. It's only a little after 1 in California.
Hi, California. It's 4:13 in New Hampshire here.
Okay, well, we only got 4 minutes, so now
Okay,
what do we do in the relate stage?
Let me see if I have this right, because this is your reputation on the online. I'm gonna tell them this is what y'all told me. So we have under vulnerability. She has low self-esteem, difficulty with trusting others. Was exposed to drugs and alcohol prenatal and has predisposition to such. Difficulty with relationships because of multiple moves in foster home. Huh?
I think the larger group is making its way back into the room.
Okay, and then the strength is resilience, resourcefulness, and adaptability. And then we're saying that her brain was probably stunted from the stem to the limbic, and she's basically probably still between the regulate and relate, which kind of like in the freeze mode. Is that correct?
She's on a flight mode right now. She's like, no, not flight, fight. She's a fight. She's in a fight mode. Yeah.
She's in that animalistic mode right now, the reptilian brain.
The primitive, in a primitive response.
Yeah.
Lauren, thank you so much.
Yes, thank you, Lauren.
Yeah.
Okay, when I do this presentation, y'all listen. If I'm missing something, please come in. Don't leave me out there like a little guppy out of water.
We won't. We got your back, Lauren. We got your back.
Oh, you overestimate us.
Got you.
Well, welcome back. Everybody is starting to trickle back into this main session. We're going to give people another minute or 2 to make their way back. Hope everybody had great discussions. Can't wait to hear about them.
Hi, Beth. Everyone's back from the breakout rooms.
Everybody is back. Excellent. Okay, well, I am going to hand this over to Dr. Hinton and Ann. I do just want to take a moment and apologize to room 10. I understand that there was some inexplicable ticking happening in your room, and I apologize. We are on that. We are looking on the Zoom databases to figure out what that was, but I'm sure that that was mighty annoying. So I apologize for that, and thank you for your persistence despite that setback. So without further ado, we are going to enter into the final part of today's session. And I'm going to hand it over to Dr. Hinton and Ann. Thank you.
Thank you, Beth. Yeah, I'm sorry about that. It sounds like it was pretty annoying in room 10. But while we're doing kudos, there's a lot of folks kind of behind the scenes from CSS that are making this run as smoothly as possible. So I would like to thank all of them that are behind the scenes helping us. It makes mine and Ann's job so much easier and less stressful that we know there's folks that are helping to organize and make Zoom work for us in these amazing ways. So thanks to all the CSS staff that are helping. So hopefully nobody's hearing any ticking now. I don't hear anything, so we're all back. What we'd like to do is to have a little opportunity for you all to share some of your discussion. And so what we'll probably do is just call on random numbers of rooms. I think there was 0 through 12. And I think what we would, instead of everybody going through everything, we're going to kind of try to highlight some. So we'll start with maybe asking 2 rooms to describe vulnerabilities and strengths of Gina and how you started with that discussion, and then move into having different groups share a little bit of it, regulate, some share relate, some share reason, if that makes sense. So I'm just going to randomly call, let's start with room 9. Would somebody from room 9 be able to share your discussion about vulnerability and strengths of Gina?
Thank you.
We're having a hard time hearing.
Vulnerabilities and strengths. Can you hear me? Is this okay?
I can hear you now.
Can you hear me?
Uh-huh.
Okay. So strength, bravery, courageousness, resilience. She's a survivor. She has perseverance, generosity, creativity. She makes bracelets. She's adaptable and flexible. She's lived in many different situations. And just some vulnerabilities is that she was removed from her mom at an early age. There's a risk of re-traumatization due to early trauma, and some impulse control, probably relating to re-traumatization.
Mm-hmm. Great. So yeah, you all found a lot of strengths in Gina. That was really nice. And thinking about not only the creativity related to what I specifically shared about things she liked to do, but just thinking about her life and her resilience to having lived through lots of different difficult situations. So very nice. Thank you, Denise. Let's go to room 3. Just randomly picking rooms. And could you all also share vulnerabilities and strengths you identified? Anybody from room 3?
Hey, it's Simone.
Hey, Simone.
Well, that was pretty much the list that was just given. I'll be honest. Because I'm looking at our list, I think she's covered it. The thing that stuck out to me really was her generosity. I don't know why that stuck out to me, just around, making the bracelets and giving them. I don't know. In regards to vulnerabilities, just noting that there's that substance abuse history in regards to her mother. I don't know if that was listed, but that was something that we had as well. And then maybe her ability to maintain well, her ability to establish and maintain connections because of moving so frequently.
Yeah, that's a real like social vulnerability of
Mhm.
like those connections.
But
Thank you. I
that's what we
really,
have.
yeah, I like the that generosity one because I think it's probably something nobody notices about her, right? Because it gets overshadowed by everything else, and there's so
Yeah.
much conflict with other people in her life that people probably miss that part of it.
Mhm.
Thanks, Simone. And you want to pick a number?
Sure. I'm trying to keep track here as we go along. Okay, so the next couple groups as we go through, if you would share your thoughts around strategies, interventions for the regulate area. So let's go with group 5.
Hi, Anne. It was Tammy. I was going to ask you guys to pick me next. Okay. For relate, well, we kind of start.
Tammy, regulate. Start at the bottom. Regulate. Sorry.
Oh, I'm sorry.
That's okay.
Yes. So things to help her with regulating is to incorporate some of the things that she is interested in and enjoys. So kind of starting to introduce the her creativity, her love of coloring, and kind of bringing those things in to help with supporting her. Also having a staff who's trained, who she can connect with, to engage her, and having that person help with grounding her to start knowing her kind of triggers and being able to be trained on knowing how to step in, to remind her of some of the things, like talking about some of the favorite music she likes to listen to. Also talking about and bringing out her journaling, since she likes to write, and starting that process of giving her those grounding techniques.
So I think you mentioned creativity and maybe coloring. If that's something that people recognize that she does like to do, that might be something in the regulate part. If it's something that is kind of routine, repetitive, that she doesn't have to think about, that she can do alone, that might be possible there.
Yes.
I think some of the things you mentioned are kind of moving from regulate to relate, and kind of starting to move that up.
Okay. We also talked about also kind of having the staff pull out her beads and start the modeling of the beads to help her draw her in for her to come, and then doing the regulations of the beading to help kind of calm her down and center her too.
Yeah.
Because that's going to tap into that kind of repetitive, right?
Repetitive motions. Yeah.
Yeah. Yeah. Okay. All right. Thanks, group 5. Let's see here. How about 10? Group 10. Continue on with thoughts around regulation.
And we decided to help regulate her emotions. We would recommend like doing things to help her cope, like counting out the beads that she uses to make her bracelets, or sorting them by colors to kind of keep her, help her practice some mindfulness. Try to teach her how to communicate her feelings verbally, helping model her behaviors for her. Trying to, like, along with this kind of goes with the first thing sort of, but when, in helping her sort out the colors of the beads, helping her maybe match an emotion with the color of the beads. So like if it's, like a red bead, maybe that could, symbolize anger, things like that. And also using her love of music to help calm her down, like teaching her to maybe play a song for each emotion that she may be experiencing. to help her regulate that way instead of maybe having meltdowns or outbursts. She could use the music to demonstrate what emotion she's feeling.
Yeah, so again, I think some of the things that you're mentioning could definitely be used in that moment, like the sorting the beads, organizing them, listening to music. But remember, this is the most basic place of the brain, right? So we're not probably going to have a lot of success in getting people to match emotions with a color. Like that would be a great expressive kind of strategy that she might be able to use as she kind of started working up, where she still may not be able to put into words emotions or how she's feeling, but she might be able, it's kind of like her own version of a stoplight system, right? Like she might be like, here's, I'm sorting yellow beads, I'm in the yellow, right? So she's kind of in between. But I think thinking about some of those strategies you're talking about to take the step back at what is a more simple approach when you're in the regulate part. But certainly some of the things that you mentioned are things that you could then build on, you know, as she starts to move more into that thinking, feeling brain. So, you know, when we're in the regulation, it's those really basic strategies that we ground, and you both mentioned it, some things, simple things like sorting something, running her hands through the beads might be the place to start, right? That has very little, there's no real verbal interaction. You might just be able to sit a big bowl of beads down in front of her that she's able to kind of stick her hands in or even start to play with in her own way. So I love that. I mean, you're definitely tapping into her interest as well, right? With the beading and with music. But this is tricky because we're always so focused on like really these positive strategies, but I think that's why it's so important to remember that regulation has to happen first. And we really have to make sure that we are tapping into the brainstem before we start going to this next level. So, so I think
I was just thinking about, Anne, if you think about some of the examples that were given, and think about what that would look like if Gina is in an altercation with her housemate about the stuffed animal, right? And they may be tugging at the stuffed animal. She may be yelling and screaming. They may be, you know, physically pushing each other. You're not going to get her to sort beads right then, right? So even backing up, what are some things initially, if she's in that whole state of, like you said, Anne, in the lowest part of her brain, really in that regulate part, what are we trying to do at that point?
Yeah.
And I think it's something as, you know, I don't mean to say as basic because it's not basic, but something as, you know, keeping her in a routine. I mean, so that, you know, she eats at the same time every day. She's going to bed and waking up at the same time every day. So, you know, she's not ever really feeling hungry, not feeling tired, hopefully. Like, I think that's really important in helping her regulate too. Because of that limbic system and, you know, the you know, which controls, I mean, those most basic types of emotions related to those things. I think
those are great
routine
preventive strategies. Yes, exactly. And that does keep everything regulated out. We were just thinking about if somebody does get to that point, kind of in that moment,
yeah,
they are really upset. The basics are kind of like trying to mirror taking deep breaths. Maybe, you know, you may have something in your hand that kind of guides her to another space so that she can have more space. So that may be her beads, or it may be music or something that you introduce and then go to a room and she goes and follows you. But there's very little interaction at that point. And then the things you were talking about are great ideas for then using her interest as you move into relate and reason areas that you can use those, and as prevention too. Like if beating is something that keeps her calm, have her do that 3 or 4 times a day at different times. Like that's something she likes. So yeah, good thing, good thoughts.
And I love, you just made me think of a person from START team I used to work with that hunger was a real, like hangry is a real thing, right? You know, when our basic needs aren't met. And actually, one of the things that the START team working with him realized is that when they did see some of the worst sort of dysregulation, he was hungry. So if we had tried other strategies, even grounding and things like that, he had a biological need that was not being met. And so one of the strategies, and this is probably a more rare situation, but we were able to really identify that this was a very much a biological factor, was that his staff or his mom or whatever would just kind of step away and go into the kitchen and he loved cheese, get some cheese out, put it on a plate, and then just like let it sit there on the counter and walk away. And he would come and be like, okay, I'm gonna have my snack, and calm down, like, okay, now I feel a little better. Get his blood sugar up. And then we'd say, okay, now let's work on like some grounding and things like that, because hungry and nothing else is really going to do it for him.
Right.
If he's got that kind of basic drive of being that hungry. So it was
about Gina's past. We know that between birth and 4, there were times when she was left alone, right? So that may, whether there was food there or she knew how to get food for herself. So that really may link back to some of that early trauma that she had.
Again, that's something we want to, a lot of assessment and kind of hypothesizing led to understanding that nothing we try until he has a little bite of something that makes him like, okay, I'm going to get a snack in a little while, allowed us then to be able to do some of those other techniques. But thank you for bringing that up, because I do think we think like Maslow's needs, right? Like if we're not addressing those basic biological needs, we're going to have a hard time. And for some people, that might be the thing that is really causing a lot of dysregulation in that moment, that's adding to everything else that's happening.
Yeah.
So, great. Thank you.
Yeah.
And as you were talking, we're getting ready to call another group. As you were talking, I was kind of going back a little bit to the vulnerabilities, and folks mentioned some of those, but thinking biopsychosocial, it made me think of that when we're talking about the hunger, that her vulnerabilities cross all of those in terms of, we talked about possible brain dysfunction due to substance use earlier in pregnancy, the trauma and the psychological trauma of that part, and then that those limited social contacts she has, and people in her life that aren't paid to be there. So she has vulnerabilities across all 3 of those. So thinking about how that impacts how we develop these strategies is important.
Definitely. Okay. You want me to pick? You want to do this one? Okay, so we're in relate. So if we worked on, might have taken us a good long amount of time, worked on getting that brain stem quieted down, not quite so hyper aroused, not so reactive to any type of stimuli or requests or anything like that. We're getting ready. We can start to move into that limbic system where we want to try to engage the limbic system in positive emotions now versus the negative fear-based emotions. It's been in while the brainstem has been dysregulated. So, so let's talk about some strategies as we are in that relate part, that limbic system part of the brain. How about, do we have a group 0?
Yes.
Oh, I like that. Let's do 0.
Just as group 0 may not know that they were group 0, but that was the group with Lauren Jackson and Michelle and Joanne, just naming a few of the names. Paul.
Okay. This is Lauren. We it's talking about the regulate and relate. We felt that her brain was probably stunted from the stem. Basically, she is in the maybe fight. I was thinking freeze mode right there, because she had just moved to this new place, to the new housing. And again, this is just more trauma for her. So when you're talking about, you want us to talk about relate, right? Is that what you said? Because we were thinking she's still in regulate. And but when you're talking about relate, there was a point where she, going back to her history, where she had to survive for those long periods of time when her mother was gone. We don't know if that was for like a half a day or 2 or 3 days, etc. So she was probably in, the way she relates to life is she showed it when she snatched that little stuffed animal, something that would be soothing to her, but she doesn't know how to ask for it because she had to always fight and snatch for everything, basically for this last 21 years in one fashion or another. You know, she had to grab for other people's relationships. She had to grab for other people's love or caring for her or acting, or even trying to get them to know how she's feeling, her feelings, how she's hurting or whatever. So she has all this going on, and she's probably, like we said, we feel like she was really instilling this regulate situation. And the way she relates is to just snatch. So dealing with her now, let me just give a little thing back on our group. We didn't quite get this far, but I told my group to step in if I'm misrepresenting.
Lauren, this is Katie. I was in your group and I can help back you up and I can guess what we might say based on our earlier conversation if you'd like.
Yeah. So
okay.
So basically you're thinking you have this person who is, they've always had to grab. They're in this freeze part right now. She's gotten a new a spot. So snatching that little stuffed animal is a way for her to say, this is something that I can see that, will help me. We would have to deal with her. I would say that working with her and those type of traumas, what you talked about as the soothing and being very gentle with her. When she's, you have to find a way to, you probably can tell by her language or her body language that she's upset or she's anxious about something. And if you can recognize that, then you can kind of head it off. You talked about the other person wanting food. That probably is a big thing in her life if she's, half a day or 2 days, 4 years old and hungry. So I think, go ahead, Katie.
And I think kind of based on that discussion, what you're saying, what we might do in some of those, that relating stage is to continue with the repetitive movements. And so it sounded like because she had those physical outbursts, it could be things like stomping or tossing something back and forth. And that next stage in terms of sorting, so going back to the crafts and the beads, having her sort those beads by colors or by size. And in terms of just those, I'm assuming we would do deep breathing and guided imagery and continue with that. And then as far as playing familiar games, it might be something where, to me, I thought of maybe it was something you would introduce, and it could be the card games or like the sand art, because she likes crafts. And so there's the sensory component of it, there's the visual stimulation, and it can be very repetitive, dumping the sand in there over and over.
I would also like to say in that thing, because she was grabbing out that little stuffed animal, stuffed animals, probably even bigger ones, would probably be more soothing to her because that's something that you can hold, that you can try to get comfort from. I think you'd get more comfort. I get more comfort from a stuffed bear that can sit by my side and I know is always there, as opposed to a bunch of beads. But that's
that might be in that bottom level of regulate. But I think, Lauren, what you were talking about earlier is an important point in terms of on an everyday basis. At this point, it feels like that Gina is kind of functioning in that regulate or just barely, like in the relate part, but not. She's got a lot of anxiety, a lot of trauma, and a lot of fear. So on an everyday basis, I think approaching her from that perspective and very gently, recognizing that she can become dysregulated really easily because she's kind of has that, as Bruce Perry describes it, that dysregulated brainstem, right? That is constantly and is vigilant about what's going on around her. And she gets triggered really easily by things which seem really scary, frightening, angry and, make her angry really quickly because she's kind of functioning in that level. So I think on an everyday basis, as some folks were mentioning, trying to do lots of things like a regular schedule, a regular meal schedule, predictability, all those things on a daily basis are going to be important for her to kind of keep her from becoming dysregulated really quickly. So I think that point is well made, that maybe she's always kind of in that regulate, and we have to really work gently and deliberately to try to get her into that relate section, because she definitely needs to create some of those social connections.
Mm-hmm.
Yeah.
And Katie, I think the strategies that you shared from what your group talked about, or where you would have gone with it, is a nice tie-in of, like we talked about, like how to kind of take some activities or grounding, very simple sort of things that you might be using and regulate, and how to kind of carry those over, as we move into the relate part of the brain. So great work, team zero. That sounds, I don't know, like
I like it.
Zero. Yeah.
There's a great movie called Troop Zero. I don't know if anybody's ever seen it, but it's a feel-good movie.
Okay, so let's maybe hear from another group on relate, and then we'll move on. So let's see, how about we'll go to the opposite end. How about 12?
Hi there, this is Sheridan, and we had Miles, Devante, Jorge, Carmen, Evelyn, and myself in group 12. For relate, a few groups have talked about relate already, so I don't think we have anything groundbreaking here, but we really talked about simple ways to rapport build with Gina. So that included really simple, expressions or talking, whatever's appropriate, about favorite songs and music. Real simple, not trying to get too analytical into it, but simply being attracted to and listening to music or songs that she likes. Having her pick out music she likes in whatever form or fashion makes best sense, whether that's tactile, physically going through CDs or scrolling through her phone, for example. Reading a part of an enjoyable book and talking about what was read, or just expressing why it was liked. So again, kind of tailoring the relating to what she's comfortable with in that moment. Again, kind of looking for signs of when we might need to go backwards into the regulate zone. And then also looking for opportunities to expand to the reasoning zone, in which case we could kind of build on those skill sets to different things like journaling and, multimedia types of things, kind of taking advantage of her creativity and her craftiness and some of the interests that she's expressed, where she's kind of in control of that expression, in control of that, of the flow of the relating with the person that she's interacting with.
Very nice. I love that. I love that you're tapping into that aspect of control, because that is so key, as Jill and Karen talked about yesterday and mentioned again today. I also, as soon as you start talking about her kind of tapping into her favorite music in a very nice way of saying, like, what's her favorite, letting her pick it, made me think back to the regulate, we're group 10, sorry, I can't remember who was talking, but you were mentioning about, like, maybe thinking about music that, sort of matched, like, if you'd worked on that ahead of time, where she could identify songs that make her feel good or make her feel happy, that would be the perfect opportunity, tying in here to what you're saying, Sheridan, about if she could pick a song, you might be able to prompt her as, like, let's pick that song that makes you feel so happy or makes you feel so good. And then she would be able to go ahead and pick that or something else if she wanted. But I just thought, like, that's a great connection to what the group 10 had mentioned about maybe working on identifying songs by the way they make us feel, right? And so we do that too. We turn on certain music or stations or whatever if we need to get a little energized or, our mood lifted. So I instantly thought of that, like when you mentioned that about having her pick some of her favorite things, that you might even have been able to do a little bit of work to tie those into things that specifically make her feel good, make her happy, make her feel safe. So, very nice. Anything you want to add to that, Jill?
No, I think that was a great example. Of, like you said, all of these, when we think about this triangle where, we're kind of focused on in the moment when somebody's upset, but what we learned from that is important. And then, you know, when somebody's in a better space, how do we learn more about them so that when we do get in these difficult situations, we have more information, more knowledge about what does calm them, what makes them happy, what makes them smile, that we can pull into that. So it's an ongoing, everyday observation and understanding.
Yeah, and if we think about things proactively, like we mentioned earlier about crisis planning, right? If we have seen that she consistently goes to one, you know, one, two, three of the same songs when we are talking about something that makes her feel good, then in Gina's plan, we would want to proactively say, put this song on for her when you're grounding, right? Like, so that might actually help that connection to those more positive emotions happen even a little faster as she's in that regulation part. So sometimes you can pair these, you know, kind of two activity levels together at the right time, sort of layer them on top of each other as we're building up, but you know, never get ahead of yourself, like we mentioned. But that would be a great proactive thing to include, to know that these are things that make her happy. So at the earliest sign that she may not be feeling very happy, let's try it.
Yep, good idea.
Okay, so now we're in our reason, we're in our prefrontal cortex. So how about group 7? The goal is now like thinking and feeling together, right?
Hi, sorry, you said reasoning?
Yes. Yes.
Okay, so we were discussing getting her to describe her surroundings, like the color, smell, and just sort of recognize what could lead her to feeling safe in her environment. We were also coming up with having her, we know she likes journaling. So that could be a space where she could think about what her next goal or step would be. It was also suggested that she could create a feel-good book. So like go through magazines or pictures of things that she could put together, which also, or even just have pictures that represent activities that make her feel good. So that maybe staff or someone could later like present that to her and be like, hey, you've made this book, like this is what makes you feel better. So that others can like prompt her to look at it. I think someone mentioned earlier, but like continue with her making bracelets, both to tie colors to coping skills as a reminder of the skills that she has for herself. I think that was mentioned earlier, but you could grow on that. So that's something she could wear herself, or her generosity was mentioned earlier. So like encourage her to make more bracelets as gifts to connect with others. Plus it's that repetitive motion that like the action itself could be relaxing to her, but then it could have that additional benefit of providing to others. And then just like the ongoing, like tell jokes, come up with some positive moments that could be shared. And just recognizing it's a forward approach. We're not trying to rehash like whatever went wrong, but just trying to figure out positive things moving forward, or things that could be fun for her. And I think
Thank you. I think that's a really important point, is that when you get to that reason part, it's not that we're going to reason with somebody and ask them why they did something, right? So it's going forward. How do we move forward, and not continue to rehash and re-traumatize people?
Great.
I like the journaling, and then that's something that may turn into one of those prevention things we do. If that's something she likes, encouraging her once a day to write something she's grateful for, or to take note of positive interactions she'd had, right? And if the other thing I would think with the bracelets is helping the staff to create situations where giving the bracelet to somebody becomes a positive interaction. Because it sounded like she was just handing them to somebody or leaving them for somebody, but it really wasn't an interaction. So how do you use something like that to actually create one of those positive interactions that, again, builds more positive connections in our brain?
Mm-hmm. Nice. The thing about journaling too is, you know, that really works well for some people if they have a hard time putting into words how they're feeling, right? And they can maybe write it down. And a good strategy is if someone, that's a really good technique for someone to use, sometimes you don't want people carrying their journal around, or they don't have it with them in that moment. And so for people that you find that that is a really go-to kind of strategy, keeping some little scraps of paper or one of those little mini notebooks that easily fit into a pocket, or other people carry paper around. Because in the moment, you know, like I've known people that are like scrabbling for something to write on because that has really become their way to express. So again, thinking ahead and saying, okay, well, you can write in your journal if it's available, but we also want to make sure if in the moment someone writing a word down or a thought down is really, really important, then let's make sure there's some paper and things accessible to them, because they can always take it back then and put it into their journal if they want to keep it. So it's a good generalizable skill. So thank you. Okay, let's how are we doing time wise? All right, let's hear from one more group about reason. What about group 2?
Hello.
Hey.
Hi. Okay, so for reason, towards the end we got a little cut off. I know some of my teammates were saying some extra things, but so I guess we were going towards the route of beginning practicing skills and potentially providing preferred item of their own. And that way we can begin acknowledging and recognizing the feelings around the stuffed animal incidents, or most or excuse me, more so being able to relate on those feelings that she had with the stuffed animals and the altercation, and maybe those feelings of jealousy or whatever that might have been, but just being able to recognize and acknowledge those feelings, and work on social regulation skills, and eventually helping her to express herself by, you know, doing, I guess, more preferred activities with her.
Mm-hmm. Yeah. So you mentioned Tiara, who's one of a brand new start team member.
Hello.
I like what you said about kind of at some point, once we're able to start helping her practice in the skills and maybe being able to express a little bit more of what are you feeling? Because, you know, I think there's a key thing in that story about the stuffed animal was that if I remember correctly, that young woman had just come home from visiting family members, right? So,
okay.
So I think it's a really important point you're making, which is there was clearly a strong emotional response that the stuffed animal sort of became the object related to it. But I think that the more deep-seated emotional trauma was really probably more tied to family and connection, right?
Right.
So what I'm saying is you're on a great track, because we would want to start, even if it's us kind of peeling those layers back a little bit, that maybe that grabbing of that stuffed animal is hurt and kind of an empty feeling, because this person has a family that they spend obviously positive time with and get nice things from and then get to come back, right? So I think it's more probably stuff we would want to be aware of and think about how to help her then start to recognize some of her emotions and how to fill that gap. So it kind of goes back to that social vulnerability. So I like that you said that. I think that's a really important point, is sometimes we have to look, the stuffed animal is a great comfort, but sometimes we think like maybe it's less about the stuffed animal and more about what that stuffed animal represents to her, you know, so we don't miss that point, you know.
So more in relation to how her mother may have promised to visit her, and she didn't come follow through, so that resulted in aggression. So it's more connected, I guess, to that sort of situation.
Yeah, so that for us, like I'm saying, is people who are supporting Gina to understand, okay, so now we have a little bit more information about, it may not necessarily be she wants her own stuffed animal, but we need to help maybe again with that social connection to her feeling like she's got a better relationship with her mom, or she's connected to other people who fill that gap a little bit if her mom doesn't come through with, you know, with a visit or something. So it's just a really good point you made. And I think it's a great thing for us as start teams that we start to peel the onion, so to speak, with people. And that gives us even more information then. Because like Jill said, we're really thinking like, what do we do right in this moment with Gina? But what you just said gives us an avenue to pursue about, okay, but what about more than just this moment? Where some of these feelings and the way she's expressing things, where is that coming from?
And I expect if we looked at her eco map that we do as part of intake, that people are paid to be with her, or her natural relationships are kind of stressed right now. So
right.
How do we create more natural relationships? How do we build? Maybe we do need to work on, and these are kind of the broader goals, right? Not in the moment goals, but what do we do overall? How do we, is it possible to repair that relationship with her mother? How do we make that stronger? And then, you all probably, this situation occurs a lot where people are expecting something to happen and it doesn't happen and they're very disappointed. And that can trigger those, like Karen Harvey talked about, those traumas of betrayal. Certainly that can be triggered by something disappointing happening. So we often work with people on plan A's and plan B's. So here's something you're really looking forward to. If it doesn't happen, here's a plan B of something else. It might not be quite as exciting, but something else good that can happen. Because what often happens is something falls through and then the person has nothing to do. So then they can ruminate on that happening and it just kind of becomes a spiral. So really trying to think of alternatives. So yeah, that was a great, thank you. And there was a couple of comments in the chat. Somebody, Kelly Smith, Val said Kelly Smith suggested keeping little sticky notes that you can like write moments of joy and you can put them around, which is a really good, kind of stays there. So it's another reminder of positive interactions. But then somebody else asked about sometimes when people journal that they begin to ruminate and just write negative things and rewrite about an incident happening. And you may have strategies. And one thing I think about is for folks that do that is creating journals that have prompts in them so that you kind of lead people to put some positive things in. So if they want to, if they feel like they need to write something that went wrong, also having what else could have happened, or so adding prompts to a journal sometimes can help that people who kind of get in that negative spiral.
Yes, and that's a good point. I mean, that's always, I have typically not been a huge fan of journals because of that, because it sometimes can keep people sort of stuck in a negative place. But if they're used and planned properly, they can be great expressive tools. So I think that's a very, very important part is, and also remember that Gina's already sometimes spends some time alone. So if we want to, if she's going to journal, and what we'd really want to do is maybe have that be something that somebody's with her when that's happening, right? Like that can also kind of help use a prompted kind of journal approach versus her going by herself into the room and maybe becoming focused in the negativity or making even more negative things than what she was currently experiencing once she starts thinking about it and writing about it. So
Karen Likely just said maybe that she suggests that people have to write 3 good things for every bad thing they write. So trying to balance it again, providing some structure for people that feel like they need to record when something bad happens, but how do we balance that out? And somebody else suggested there's a journal out there. I've seen these in bookstores called Wreck It, which allows you to express different emotions, I think. But it guides you through, if I remember that correctly.
Great. Well, thank you. That was fantastic. I know it wasn't a lot of time and it was complex. Maybe we should have signed people different levels because you probably didn't have quite enough time to get through all 3 of them. But thank you, everybody's wonderful ideas, wonderful suggestions. And hopefully today's conversation and topic has been helpful from a practical standpoint of, we know so many people experience trauma and what do we do about it?
And I think that we really want you to connect from a START perspective that the things we're doing and the things we teach and START, there's a reason behind all of them. When you think about trauma-informed care and our START practices, thinking back to executive functioning, how the brain's functioning, what trauma has done to somebody's brain, that connects to what we're doing, right? So there's rationale and reason behind why we're doing these things and why we focus on strengths and why we push people toward PERMA and why we try to identify those vulnerabilities. So we're trying to connect the dots, I guess is what we're trying to do today. So hopefully that has happened for you all.
Thank you very much, Dr. Hinton and Anne, for doing just that, for connecting the dots for everybody today. Another great session. Thank you, everybody, for attending and engaging and participating. The evaluation link will be posted in the chat for today's session, and it will also be emailed to you. Continuing education credits will be available through the event website. And finally, just a reminder that the Zoom session, the Zoom link is the same for all 3 days, and we hope to see you back tomorrow at 1 p.m. Eastern, 10 a.m. Pacific for our final session, where we will watch and discuss the recently released START documentary film. Thank
Yay,
you
that's
all.
exciting.